as our group and walked through and demonstrated doing the process. The shortcoming of that, it was an excellent process there. We just didn't have any way of doing it for the patients. We are computer poor at our facility, so we just did not have that, but it's something that we are still working on getting accomplished. After they get back from the lab, the next person to see them is the nurse. And she's doing the screening and she sees them with their little baggies. And she will go through the reason that it's important to get the test and that Dr. really wants you to get this accomplished because doctor's worried about it. We should put them in the room, and then it's my job to get them to the point where they will actually get the test back. And also to catch those that I know I've ordered it on, and to educate them on the importance of going back down to the lab, pick them up. I talk with them about the importance of early screening, about the survival rates. I talk with them about how the alternatives are having someone look at your backside that you don't know becomes an issue, as well as the horrors of getting through that prep. We get 100% accuracy when they return it. We get 30% return rate initially. That's when the nurses go back and do the follow-up calls. We get another 10 to 15, maybe sometimes 20% brought back in. That's how we manage to get up to when it truly does take an effort of every single person who comes into contact with the patient, educating them on the importance and the simplicity, actually, of getting the test done. Now, the patients who've been through it once, they know I'm going to do it again, so they're pretty good about getting it back. And in the past week, I've had 3 patients say, "You didn't order my parts." So I figure I succeeded if I let that happen.
Okay, we were so excited to be able to actually hear them. We jumped just ahead just a little bit. I'm Susan Mormon. I'm with the North Dakota Department of Health. I'm in the Division of Cancer Prevention and Control. And I personally would like to thank each of you for coming and spending your day with us. As you have heard, the panel is going to be talking about how they are using stool tests to increase their colorectal cancer screening rates. And here in Jamestown, we have 4 additional individuals that are going to help us do that. And our first one up on the docket is Chastity Dolbeck. And Deb, ooh, I'm going to massacre that name. Kasanke. Thank you. Take it away, ladies.
Joyce. Is your gun working? I'll get it here.
Okay, good afternoon. We're going to be presenting from Coal Country Community Health Center this afternoon on our approach to improving colorectal cancer screening rates through the FluFit campaign and using a community approach through our medical neighborhood. We started last summer, 2015, and we met together with a group. We decided to include Custer Health, which is our local public health unit, of course Coal Country, one of our local pharmacies, and the other rural health clinic that is now a service delivery site of Coal Country in Hazen. The 4 of us met multiple times. We used resources from flufit.org. We used the American Cancer Society Flu FOBT Implementation Guide for Primary Care Providers. We watched a webcast by the American Cancer Society on using FluFit or Flu FOBT, a proven approach to increasing colorectal cancer screening. And we included some of additional team members, billing, some of our operational directors, just to kind of walk through what that process is going to look like. So we, again, met several times, created our action plan. Some of the things that we tried to put together were screening forms. We made a couple mistakes and lessons learned, and Deb will talk about that in a little bit. We used a vaccine administration record, of course, the screening form for flu and the screening form for the FIT card. And so we had quite a few papers going and a lot of commotion when we actually implemented the flu FIT a couple days that we did the flu FIT campaign. In addition to the action plan that we did, we also decided on how are we going to track what if we gave out the FIT cards. And we utilized our protocol within Coal Country Community Health Center and looked at how that recall process was going to look across the spectrum, whether that was with Custer Health, the pharmacy, the Rural Health Clinic, or at Coal Country. In addition to the resources that I had mentioned, we also utilized our standing orders and clinical guidelines that have been developed and continuously updated by our medical director, Dr. Erin Garman. And we're to that point now at about a month prior to our Flu Fit campaign last fall, and I'll hand it over to Deb Kasanke.
So about a month prior to our Flu Fit clinic, we did some training for all of them involved, including our pharmacist, who was very willing to do the FIT cards along with him immunizations with the flu. And then we also did advertising. We did like table tents. We got into our local paper. Actually, we put backpack flyers in at the school so they could get their grandparents and mom and dad if necessary there. And then with the supplies, we changed from the 3-card system to the 1-card, the HemoSure card. And so that we've had a better rate of return with that, we find also. We did a population health review of all our patients 50 to 75 years in preparation, so we knew who would be needing a card if they came in for their flu vaccine. And we also did a population health review of the patients that would need the pneumonia vaccination also. So we added the pneumonia vaccinations along with the flu fit, and we had good results with that. And so on the flu day, we did the screening if they were eligible. So we went through all the patients and asked all the questions to determine they were eligible for the FIT card. And then if they were eligible, we gave them a card and put a return date. So we gave them 2 weeks to return, and then we did do recalls on those in 2 weeks. And then if they were our patients and belonged in our clinic, we deferred and ordered and created the tracking through our EMR. And if they weren't, we kept a list of those so we could track those also. And then we did do follow-up of all the abnormals throughout the community and did a referral for those. So lessons learned. I guess you need quite a few staff to handle the screening portion of it. We found that we would fall behind if we didn't have enough staff members to screen. And then also we condensed our form. We started with 2 consent forms, and we put that onto 1 consent form as the screening for the FIT card and the flu vaccination. So, and then the return date was also an afterthought. So I guess that's all I have.
And so I'll just follow up with some total numbers to just kind of to prove that it was a successful event. During the 2 days that we held the campaign, both in Beulah and in Hazen, in our service area, we screened 289 patients. 41 FIT cards were handed out with an 81% return rate following our recall protocol. We did have three positives that required follow-up. And out of the patients that we screened, we also gave out 43 PPSV 23s or PCV 13s for pneumococcal updates. So as of May 2016, we started at about 29% in 2012, and as of current, we're at 73%, with Flu Fit being one of our projects that we worked on.
You're making it easy for me. I don't have to be that taskmaster. My 80-year-old mother and I swim at the Y 3 times a week, and she says she often understands why they call me Sarge now. because I really make her do those exercises. But you guys are making it easy here. I don't have to tell anybody or what to say, hey, time's up. Okay, our next one is Donna Lunday St. Clair and Marianne Young Eagle. Donna is with the Turtle Mountain Tribal Health, and Marianne is a public health nurse at Quentin Burdick Healthcare Facility. And we're going to learn how they increase their screening rates using stool tests.
Well, first of all, our tribe received a mini grant from the Northern Plains Comprehensive Cancer Control Program. And the name of our grant was Colorectal Cancer Screening Saves Lives. Our goal was to increase the number of community members that get colorectal cancer in our community and to increase the knowledge of community members on colorectal cancer. Our objective was to increase at least 500 community members on the knowledge of colorectal cancer and to increase at least 100 tribal members to be screened. So here's what we did. We decided that the monthly senior meal would be ideal for doing such a project. Our focus was ages 45 to 75. We had public health nursing, the community health representatives, and ourselves, tribal health. We contacted the local casino to ask them if it was okay to set up on senior meal day, which was every second Wednesday of the month, and they approved us. But prior to all of this, we had American Indian Cancer Foundation out of Minnesota come up and do some training for all of the CHRs, and Spirit Lake was also involved with coming up and getting that same training. We provided flip charts such as these really nice charts, a really educational tool. Since Native American people are visual people, we educated them on everything. It was awesome. Working with the physician's assistants at IHS, she agreed that she would write the prescriptions for the IFOBTs, and the lab agreed to do the testing for all of the results for the IFOBTs. CHRs educated all the patients on colorectal cancer using the flip charts. Public health nurses did demonstrations on the IFOBT cards, and we provided little kits such as, we just put the little IFOBT screening kit together with the instructions. We provided a little card with the information that they needed to put on there. It was their name, their birth date. We signed off on it. Once they brought it to the lab would sign off on it. They would bring it back to our department, Tribal Health, and we would provide a $25 gift certificate for them if they did such. So with that, I will hand it over to Marianne.
We started out in December of 2015 with the kickoff, and in December we educated 37 people. There was 18 returns, 16 were female and 2 were male. In January we didn't have our funding, so we didn't do the screening in that month. February we had 45 people that came through, and 23 returned their tests. 16 were female and 7 were male. March we had 35 and 15 returned their tests. 9 were female and 6 were male. In April we had 48 and 22 returned their kits, and 16 were female, 6 were male. May we had 12 and 6 female and male. So total, we educated 195 people. 90 of them returned their test kits, which is 46%. 70% were female and 30% were male.
The public health nurses gave the instructions on how to do the FOBT kits. Once they brought the kit back, the kit and the card were brought back. Like I said, they got their incentive. We encouraged the client to do the screening at home. Patients love doing this test at home because we told them that, why don't you do this yearly? And they thought, well, instead of getting a colonoscopy, Native people hate getting colonoscopies, especially the men. So tribal health education, we kept track of all of the cards that were returned back to us. IHS kept track of all of the total positives. If there was a positive, the physician assistant would contact the individuals and let them know that they had a positive, and public health nurses also did follow up. The key to our success is we all work together. Educating the clients on how to do the test was a key, and also just the Native Americans were visual, like I said, and just being able to see how to do the test, they were more apt to take the test home. Since many elders are living in poverty and they are very happy to receive that incentive. And we did it where they could get the incentive anywhere. They didn't have to go to Walmart, which is like 38 miles away from where we live, so they were able to spend it right locally at home. Thank you.
Thanks to each of the facilities that were willing to share their success. Are there any questions from the group? Okay, seeing none, at least I'm thinking I'm seeing none. I'm wearing my glasses, I can't see out there. We'll move on to the next part.
Let's give our panelists in South and North Dakota another round of applause. We're going to be bringing Dr. Brooks back up for another section of the agenda, and then move into our breakout. So just a couple of housekeeping items. The document that Dr. Brooks was referring to regarding screening guidelines, cancer screening guidelines, we did not include in your organizational jump drive, but we will send that out to you as an email, and it will also go on the 80% by 2018 link that we'll be sharing with you as well. And if you are a prolific note taker, I don't know if you're running out of paper. I did put some paper back out on the table in the hallway if anybody needs more paper. And which is starting in here for the breakout first. All right, so those of you that